Hello, everyone. Happy 2025. I'm Casey Peluso of Parkinson Foundation, Western Pennsylvania. Welcome to the first Talk with the Doc session of this year. We have Dr. Timothy Leichliter of Allegheny Health Network hosting as always, and I will just pass it on to him. Dr. Leichliter, thank you as always.
Thank you, Casey.
You're welcome.
Welcome to 2025. I'm feeling good about 2025. I don't know why. I got a good feeling about 2025. I'm optimistic. This is going to be a good year. I don't have anything to base that on, but I'm feeling it. Well, welcome back to everybody. This is the first one of the year. Um, so hopefully it'll be fun. As Casey mentioned, I didn't get a whole lot of questions in my email, just really one. Um, so this may be a short talk, or again, if you guys have questions or things you want to know, type them in the chat box. I'll pick them up one at a time as they come in. Again, some general rules of thumb. If you've never been here before, welcome to the party. If you've been here before, welcome back to the party. I'm Dr. Leichliter, sitting here in my office at Allegheny General Hospital, which is now in the back of the building as opposed to the front of the building as I used to be. And I'm here to answer your questions. This is a good general question and answer session. So this is not a great place to get your own individualized therapy. I highly suggest having open communication with your neurologist or your doctor. But if you have general questions, then feel free to type them in the chat and I'll answer them. The other thing I like to tell people is everything you hear is my opinion. I have a lot of opinions. I will tell you my opinions. I will give you all kinds of opinions, but it is just my opinion nonetheless. And so if you have a different doctor or a different neurologist or a different movement disorder specialist, they may have differing opinions. I like to think a lot of what I talk about is based as scientifically as I can, but as anybody who's been dealing with this or working in this field knows, there's not always evidence for all the things that we want evidence for. And so sometimes I do make stuff up, in which case I will tell you I am making stuff up. With that being said, I'm drinking lemon lift today. So some sort of lemon black tea. We'll see how that goes, and I'll get started. So the only questions that I got in my email were really about mood, which this is actually I don't know how long I've been answering questions for, Casey. I don't even know if you know how long I've been answering questions for, but at the end of the day, I've never actually had this question. So I thought this was interesting. And the question was something around the idea, why isn't carbidopa levodopa used by those without Parkinson's disease to improve mood? And what would happen if somebody who didn't have Parkinson's disease tried carbidopa levodopa, and has it ever been abused? And so I thought this was an interesting line of questions because I've never really thought about it that much. And I've never answered this question. So I did look a little bit into this. And as far as I know, I can't find any use of carbidopa levodopa for depression or for mood specifically. Now, interestingly enough, and you've probably heard me talk about this, is dopamine is indeed in the limbic system. And so it is in the mood system. It's the reward chemical. It's what, oftentimes does lead to elevated mood when you've released it in quote unquote normal people. And so I did start to wonder, why isn't it used for mood? And I didn't find a good answer for that just yet. So more to come maybe at some point on that one. But interestingly enough, some mood medicines do use, or some of the mood medicines we use are aimed at dopamine. And the one that comes up that actually my nurse practitioner schooled me on earlier today was Wellbutrin or bupropion. So this is actually a dopamine and norepinephrine reuptake inhibitor. Most of the time when we think about antidepressants and anti-anxiety medicines, they work more on serotonin and norepinephrine, which are also along the lines of the mood pathway. But it does make me wonder why dopamine medicines might not be used more often. And I don't have a good answer for that. But that also got me thinking that perhaps medicines like Wellbutrin would be better for people with Parkinson's disease. Now, I don't think that's statistically proven. I haven't come across any literature to suggest that. But just going based on its mechanism of action, since it does seem to work on dopamine a little bit more than the other antidepressants do, maybe it's something you'll see me use more of kind of now that I've put two and two together. And so that was an interesting question. I don't have a great answer for it because I haven't done enough research to look into it. But as far as I know, specifically Cinemet has not been used in mood, particularly outside of the diagnosis of Parkinson's disease. I'm not exactly sure what would happen if somebody who didn't have Parkinson's disease tried a dose of Cinemet. Um, I mean, I have a feeling it would do something from a mood standpoint. If anything, it may make you dyskinetic because you already have enough dopamine theoretically. Um, but I can't say that I've ever tried that either. I personally have never tried it, so I don't know exactly what would happen. Maybe if there's a caregiver out there who's inadvertently or on purpose taking somebody else's medicine, maybe they can school us on that. So I'm not really sure I know the answer to that one either. And then the last part of the question I thought was interesting. Has it ever been abused? This is where we start to think about the dopamine medicines. And you definitely see things like this more with the dopamine agonists, i.e., the pramipexole, the Requip or Ropinirole, the rotigotine, the Nupro patch to a lesser extent. But this is where you get something like a dopamine dysregulation syndrome. So, because dopamine does work in the limbic system, in the mood pathways and the reward pathways, it does get abused or potentially kind of addicted to it. And you see this in something called dopamine dysregulation syndrome, which is usually again with a dopamine agonist, and it's usually noticeable when you start taking people off of it. It can be noticed when people come back and constantly need more and more and a higher dose, um, more quicker than you would expect disease progression or symptom relief. And then you try tapering it down, and people can actually go through an underlying withdrawal from these medicines. Again, usually you probably see it most commonly with something like Mirapex, but I have a feeling it's been written about or talked about in Cinemet as well. And so I don't know that anybody has necessarily specifically used it for getting high or an abuse potential, but there is definitely well documented cases and a condition where you can become more or less addicted to the dopamine drugs that we use to help you from a movement standpoint. And that becomes a little bit tricky when you're escalating dosages or when you're trying to take people off of it. And so I thought that was a very interesting line of questions because I've never actually gotten questions about it. I've never really thought about dopamine or particularly carbidopa, levodopa, cinnamon, or really any of the Parkinson's disease drugs being used outside of the setting of somebody with Parkinson's disease or Parkinsonism or dystonia. Um, but that kind of got me thinking, and maybe you will see me kind of adjust the treatment of depression or mood or things like that in some of my patients just to see if that helps any better. But again, I thought that was an interesting question, and that was the only question I had in my email. So nonetheless, that was what I got. Um, we all learned something on that one, I think. All right, now I'm going to scroll up to your questions over here in the sidebar, and I'll take them one at a time. So feel free to keep putting them in there. I'll keep answering them as they come in. How interesting question. How does stress affect the progression of the disease? I don't know that I necessarily know the answer to that question. I have a theoretical answer to that question. So stress definitely amplifies symptoms. So every single patient that I get coming to my office for tremors and stiffness or walking problems, Parkinson's disease or otherwise, if you have an underlying movement disorder, there are certain things that are going to make it worse. Every single patient that comes to my office, if you're stressed, if you're nervous, if you're anxious, if you're angry or upset, if you're overly cold, if you drink too much caffeine, if you're overly tired, this makes everything worse. It always amplifies symptoms. If you get a urinary tract infection or an infection, a COVID, a flu, a cold, it makes symptoms worse. Now, I don't know, and that's true pretty much across the board. I don't know if that necessarily takes it one step further to affecting the progression of the disease, because that's a little bit different. So, progression of the disease is more than just how bad your symptoms are, it's kind of a trend over time. Now, I can theorize, I don't know that this has been written, that anything that stresses the brain stresses your system, which is why it amplifies your physical symptoms. It could also knock off a few more dopamine producing cells, inflame a few more mitochondria, kind of tax the system a little bit more so that those cells are not as good as they should be or do take a hit. And so I can theorize that, again, if stress, particularly if it's prolonged, any type of underlying infection or inflammatory process, I think if these things are there long enough and you're stressing the system long enough, I can theorize or I could guess, or logic to me tells me that that could indeed increase the rate of progression. Now, since we don't really know the underlying cause or the true underlying pathophysiological mechanism as to what triggers the disease and makes it progress, I can't say that for sure. But logic tells me in my head that if you do anything for any length of time, it's going to become a more permanent thing. And so I would have to imagine that not necessarily a stressful event, although you could argue maybe it does. But if you have long-term stress or high levels of anxiety pretty chronically, I could see where that would make things progress a little bit quicker. Again, that's all a lot of guesswork. I can't say that for sure. But at the end of the day, I wouldn't be surprised if at some point, at some time when we figure all this stuff out, we say, hey, people who are under a lot of stress or have chronic levels of high anxiety, high stress, high inflammation systems do progress at a faster rate. Then the follow-up question is, can a person reverse the progression? And I think the answer to that question, at least to my knowledge, is no. I don't think there is a reversal to the progression. The idea behind everything I talk about, which is hugely about exercise, being active, being as healthy as you can, again, mainly through physical activity and exercise, is to slow down the rate of progression. But I don't think I can ever actually make it stop. And I certainly don't think I can ever have you guys or anything I can do can make it go in the other direction. Now, coming back to relating that to the first part of the question, if you have transient things, so let's say you're under a lot of stress for a temporary amount of time, or you get sick with something, and that flares up your symptoms. If that stress is relieved, or if that illness is fixed with an antibiotic or whatever, that can make your symptoms improve. But I don't think that's actually reversing progression. That's just kind of getting you back to your baseline, which was flared up because of some other underlying thing. And so I don't think, at least to my knowledge, and at least with the medical knowledge that I'm aware of, I don't think I have anything that necessarily reverses the progression. The best we can do, as far as I know, is try to slow it down or keep it going as slow as possible. And the only thing I know that does that is exercise, which is why I harp on it so much. And so, again, those are interesting questions too. And that's how I generally think about all these things when patients are sitting in front of me or they send me a message in terms of, hey, I'm noticing an acute change in my symptoms, or hey, I'm under a lot of stress, or I have a cold or a flu, or I've just been severely dehydrated and my symptoms are worse. That's kind of how I view that. Is the new AbbVie subcutaneous pump as promising as it sounds? Is anything ever really as promising as it sounds? I mean, really. Um, I don't know. Good question. So, for those of you who don't know, there is a new subcutaneous infusion of a version of levodopa. It is called Vyalev. Look at that. Still working up there. And so this was just approved fairly recently, but the caveat is, at least according to what I know, is it's right now only available to young, quote unquote, young people, i.e., I think younger than 62 or 63, and on commercial insurance, which I can tell you is not the vast majority of my patients. And so I have only been able to order this for a handful of people so far, and I've only hooked up one. And I just did that not last week, because last week I was off the week before last week. And so I do not have enough experience yet personally to say yay or nay. If it does what they tell me it does, and the idea behind the subcutaneous infusion is basically a lot like an insulin pump, where it will subcutaneously, i.e., under the skin, through a small catheter that's inserted with this needle patch, directly infuse levodopa into you 24/7. You wear it all day, you wear it all night. And again, the idea is that a lot of the problems that we run into with levodopa and basically all of the medicines that we use is the pulsatile nature that we give it. So I've said this before, but it's worth repeating. The way that we deliver the chemicals to your brain is very, very, very unnatural. In quote unquote normal people, and believe me, I don't know any normal people, but if we found a normal person, their brain is not putting out a burst of dopamine every 4 hours and then it wears off. That is a very unnatural way for somebody to receive a chemical, a mind or brain altering chemical. And yet that's what we're doing, right? You take a pill, you get a burst of dopamine and then it wears off over the next few hours until you take your next pill. And so the way that we replace chemicals in your brain is very unnatural for typical living. But to this point, it's really been the best we can do. And we've learned a long time ago, there's a lot of papers written about this, that the side effects of the medicines, the motor fluctuations, the dyskinesias, even maybe the hallucinations or some of the other side effects to the medicines are due to the way that we deliver it in you. It is due to the fact that it's a pill, it's a burst, and then it's a taper in fairly short order of medicine. And so, if that really is the case, then theoretically, if we can give you some sort of steady state of medicine, then that should significantly have lower side effects or be less risky than the way that we do it now. The downside is, and traditionally up until this infusion was, we did have a pump, and I've used it a handful of times. The downside to that pump is you had to have a tube put in. You had this cartridge, and it infused into your small intestines, so it still had to be absorbed through the GI system. And it was really only a 16-hour pump. It wasn't overnight. And so you can understand why a subcutaneous infusion that's 24/7 is kind of a step up in that ball game, or that area of delivery system. Again, from what I'm told by the reps, we're looking to, my guess is probably mid next year before Medicare and Medicaid pick it up. And so again, the vast majority of my patients are on Medicare and they're older than 62, 63. So this really doesn't help or impact the large masses of my patients. But that does give me about 6 months or so to use it in some of my younger people, maybe some people who have a lot of fluctuations. So maybe I'll get a little bit of experience with it before it's available for everybody. So more to come. I won't say it's as promising as it sounds because I don't know yet, but I am equally as optimistic as you guys that it's going to be a very useful tool. That's a great question. Does Parkinson's impact or compromise the immune system at all? I'm trying to think if I've ever read a paper on that. I don't think I have ever once seen a paper written about Parkinson's disease patients' susceptibility to infection. Um, I don't think I've ever come across a paper on that. My first guess would be to say yes, is that Parkinson's disease impacts everything, every system, every aspect, every part. But I don't know that I can back that up with any literature that I've ever seen. I think that's just kind of my first intuition and my gut feeling. I mean, I have to assume that, if your systems are already being brought down by lack of chemicals in your brain, that you would be more susceptible to infections, to inflammation, to different processes like that, just because all of your systems are impacted, including the ones that clear things. I'm going to have to look that one up. I honestly don't know. I'm going to see if I can find any papers written about that. I don't think I have ever come across any in my experience, but that's an interesting question. I'll look it up for you. Sorry, I'm taking a note. Okay, so that's interesting. So my wife did not have Parkinson's. Carbidopa levodopa did not appear to affect her when she was misdiagnosed. And I agree. Believe me, I have given carbidopa levodopa to plenty of patients who then I decided I did not think had true Parkinson's disease. And I don't think anybody's ever come back and said it, but I don't know that I've ever had somebody who was relatively normal take it for any extended periods of time and tell me that there was an issue. This is an oldie but a goodie. This is a question that I come across fairly frequently, and I feel like it's worth talking about again because everybody at some point in time has had this question. Explain once again the difference between Parkinson's disease and Parkinsonism. And this is important, and you're going to get my philosophy on this, which may not be the same as somebody else's, but and I will tell you why this is my philosophy. Parkinsonism is a constellation of symptoms. Parkinson's disease is a specific disease setting. Let me explain that a little bit. Parkinsonism is anybody who has the right type of tremor, stiffness, slowness of movement, balance problems. These are the cardinal features of Parkinsonism. Parkinson's disease just happens to be the most common cause of Parkinsonism. Parkinsonism includes not just true Parkinson's disease, but the atypical Parkinson's like conditions, the Parkinson's plus conditions, medication induced Parkinsonism, vascular Parkinsonism, other types of things that can give you those symptoms. So, anybody who has those symptoms for any cause has Parkinsonism. Parkinson's disease is when you have the disease itself, and the disease itself is really typical. So, what I mean by that is, I really reserve calling somebody Parkinson's disease unless they have a typical presentation, tremors, stiffness, slowness of movement, balance problems, not although not falling right away, typical age, early 60s, anywhere from 50s to 70. Again, just because I call it Parkinsonism does not mean it is not actually Parkinson's disease. You can get Parkinson's disease at age 30 or 90. It's just less common. And so when I see some of those things, I am much more prone to call that Parkinsonism until I see how it goes. So the other things outside of typical presentation that tips me in the direction that, hey, I think this is Parkinson's disease is how it progresses over time. I have a good understanding of how I think somebody with typical Parkinson's disease should progress, how long it should take for certain things to happen within a ballpark. I also have a good understanding or a good idea of how somebody with Parkinson's disease should respond when I put them on medicine, particularly carbidopa levodopa. And so, really, if you're coming to me and I label you with Parkinson's disease, it's because I think everything is fairly typical. Your presentation was typical, your response to medicine was typical, your progression has been typical. There hasn't been any other causes that I can uncover to explain why you have these symptoms, all of which would put you in the category of Parkinsonism, not Parkinson's disease. And the reason why I make that distinction, and this it's not uncommon for me to get a patient from somebody else who is labeled as Parkinson's disease, and then me to go, well, I mean, I may keep calling you that, but I probably would have called you Parkinsonism if it were up to me. And I make that distinction really for one reason. It's because if I have somebody who has who I feel like has typical Parkinson's disease, I have a pretty good idea of what to expect. And I have a pretty good idea of what to tell you what to expect moving forward, what to look for, how I expect it to go, how I expect you to respond to the medicines, how I expect to layer in different medicines. It's not written in stone. Everybody is a little bit different and everybody progresses a little bit differently, but I have a fairly good ballpark idea, at least in my head, what I expect to happen if and when I do each step. And if anything is atypical, if there's an underlying cause or it's medication induced, or maybe there's some vascular disease, or maybe you're a little bit older or younger than I would expect, or you're progressing a little bit quicker than I would expect, or your symptoms aren't happening in the correct order, maybe you're coming in with falling first, which would be unusual for typical Parkinson's disease, then I am much less optimistic, sure, confident in guessing what's happening next and at what pace. So I'm much less able to describe what's coming to you or give you an idea of what's going to happen because I'm not sure. And so that's really the only reason why I even make a distinction is because in true Parkinson's disease, I have a pretty good idea of what's going to happen. And in anything that's atypical, I'm not sure. And so it really comes down to how I talk to you as a patient. If I have somebody who I think has Parkinson's disease, I say, here, I'm going to put you on levodopa. This is what I expect to happen. If it doesn't happen, you let me know. Whereas if I have somebody who I label as Parkinsonism, the conversation is going to go a little bit differently. I'm going to say, well, I'm not sure what we're dealing with, but this is still the best medicine that I have. Let's see what happens. That sounds pretty similar, but I'm actually conveying different messages and different information depending on how I word it. And so that's where you'll see me use the differences between Parkinson's disease and Parkinsonism. Obviously, if it's drug induced or it's vascular or it's a Parkinson's plus condition, we're not going to be confused as to whether or not it's Parkinson's disease. But I can tell you there's a lot of atypical variants out there, things that are just different that don't fit into any of those categories nicely that somebody else might call Parkinson's disease that I'm going to call Parkinsonism. And it comes back to the fact that if I see that atypical nature of what you have, I'm not going to be as confident in telling you what to expect. That's how I use the words differently. That's what if you're my patient, that's what your notes will kind of relay. But again, that's just my opinion. There are a lot of other people, particularly primary care doctors or general neurologists, who will just call most things Parkinson's disease and say, well, it's Parkinson's disease. Well, okay, but that I feel like isn't as useful because it doesn't tell you what's coming down the road, or it makes it harder to predict. Do you ever test the CRP lab specific for the brain to see how Parkinson's is progressing? Well, no, because I didn't know there was a brain specific C reactive protein, and I've never seen it ordered. So the C reactive protein is a marker of inflammation. I liken it to a sedimentation rate. These are general markers of inflammation, and they test the whole system. So I've never seen any that have been overly specific for the brain. Um, and I also question whether or not that would really truly help decide whether or not things are progressing or not. Um, the hard part about those types of conditions is they're going to be positive if there's anything inflammatory. So if there's anything inflaming the system, it's going to make markers of inflammation like the CRP and other lab values elevated. But I don't think it would necessarily be able to tell you, is that altering progression? Is that just a one-time event? Is that a temporary influx and then it's going to go back down? I feel like that would be much like measuring dopamine levels. It's such a fluctuating thing. I feel like that would be really hard to use accurately to make that type of a guess. Hmm. Yep, you and everybody else. So I have group members in senior living facilities that are not getting their medications on time. What are the dangers? I mean, it's just like when you're in the hospital. I mean, when you're in the hospital, nobody ever gets their medicines on time. They don't, quote unquote, have to. It depends. In some people and in some cases, no big deal. I have patients that take medicines on a flexible schedule. I just had a patient today who's like, yeah, if I'm feeling good, I wait a couple of hours to take my pills. Sometimes it works, sometimes it doesn't. And I have a lot of patients that do have some flexibility in how regimented they are with medicines. And so if you're a patient like that, excuse me, then it's probably not that big of a deal. However, I also have a lot of patients that are very, very regimented with their medicines, and they know exactly when they need to take their pills. And if they're at all late, then bad things happen. And then obviously those patients would not be as very good in that type of a setting. But I'm going to give you a hint. Anytime you're in any type of living facilities, hospitals, skilled nursing facilities, inpatient rehab facilities, anything or anywhere where somebody else is in control of getting your medicines, there is a high likelihood that you are not going to get your medicines on time. So if you take the hospital, for instance, nurses have an hour on either side of the dose time schedule to give you that pill. And if you're somebody who really needs it on time, that's not going to go so well. If you're a little bit late, you're going to be worn off and you're probably not going to catch up very well. Or let's say they give one pill late and then one pill early. Now you're floridly dyskinetic or hallucinating. And so these are real issues with a lot of patients, which is why, again, we have to be extremely cautious and careful to really try to stay out of the hospital as much as possible. But again, and then it also requires a lot of communication. So sometimes you have a very understanding living facility and you have people there that actually care. And you can talk to them and say, look, it's really important that I get my medicines on time. And I've had some people where that works and they're able to either be first on the list or, sometimes the nurse or whoever it is will go out of order in terms of handing out their medicines, and then likewise, sometimes they ignore it and they don't care and they don't do that. But if you can have an open dialogue or open communication with the people there, especially either the kind of nurse manager or whoever's in charge, then that might help. But it's a tough one. I have a lot of patients who are in any type of living facility or arrangement where no matter how much they talk to people or what they do or their wife or their daughter or their kids, it's just the way that that facility runs and they just cannot get their medicines on the time that they need, and it's a tough one. Sometimes we adjust it. We can adjust medicines based on that, but not always. And it is a difficulty for people who are those types of people where everything has to be right on time and regimented for them to feel the best they can. Definitely not an easy situation, but that's something that if you are in that situation, it's definitely worth talking to as many people there as you can to see if there's anything they can do. I mean, the worst they can tell you is no. I get told no all the time, so you might as well at least try. But I guarantee if you don't ask and if you don't talk to them, there's no way they're going to know how important it is to stay on time with your medicines. I don't know the answer to this question. Does DBS slow the progression of the disease? The very first answer I would say is no. The studies that we have so far have suggested that much like all of the medicines that we use for Parkinson's disease, is that it's symptom management only. It is not actually altering the progression or the disease course. However, there are those out there who think if we implanted early enough that it would actually slow down the disease progression. I'm kind of up in the air. I'm on the fence on that one. I mean, again, I've seen enough people who do really well with deep brain stimulator surgery to think maybe there is something to that electrical signal and altering those currents that are going through your brain to get them into a more normal firing pattern, which is what we think DBS does. That maybe if we did that soon enough and we corrected that abnormal circuitry, that could we actually slow down disease progression? But the other half of me says we've never done that and we've never proven that. And so the evidence does not suggest that it is indeed disease modifying. And so the short answer to the question is no. But the much longer answer to the question is, well, maybe we just haven't done it right yet. More to come. Why not Cinemet ER during the daytime? Great question. Because if you're my patient, you know that I don't like to do that. And here's why. So carbidopa levodopa comes in a whole bunch of different varieties. The regular quote unquote Cinemet, which I don't think anybody actually makes brand Cinemet anymore, but that's what I'm going to call it because it's a whole lot easier than saying carbidopa levodopa 15 times. Um, Regular Cinemet immediate release is still, as far as I am concerned, the gold standard medicine for Parkinson's disease. The 25/100 dose is really the best pill that I have that I can give you. Why do I think that? Well, because it has the most data to support its use, and I can tell you in my 10 years, it's been the best pill that I've given to people. Why is it the best pill that I've given to people? Two reasons. One, it works. And when I say it works, people feel it work. It and not everybody, so take this with a grain of salt. It kicks in. People, after a while, people feel better. They can feel it work. And then it wears off. But it's that feeling work that I think really does help people know that, okay, this is really doing something. And statistically, it actually impacts quality of life better than any of the other medicines that we have. And so that's why I think it's the best drug that I have. Immediate release Cinemet comes in a couple other doses. So it comes in a 10/100 and a 25/250. I don't generally use those other dosages because, again, in my opinion, the immediate release 25/100 is the gold standard pill. So instead of increasing the dosage or decreasing the doses outside of some extenuating circumstances, I just alter the number of pills that you take. That I have found to be the best way to adjust and the easiest way to adjust the dose to try to accomplish what we're trying to accomplish. There is a Cinemet CR, or a controlled release version of Cinemet. This has been around for quite a, I don't know how long, but a while. And it does last a little bit longer than the regular immediate release Cinemet. What it doesn't do is people don't usually feel it work. And that's why I don't use it very much during the day. Patients, in my experience, really like to feel it work. Not to say it doesn't work, they just don't feel it work. And when they don't feel it work, especially if they're used to the immediate release, they feel like it's not as effective, even if it lasts a little bit longer. So the one time you will see me use the Cinemet CR is at bedtime. If you are not lasting overnight, because again, regular Cinemet doesn't last very long, if you're waking up off or if you're waking up in the middle of the night very stiff and slow, a controlled release version of Cinemet might be useful. It does last a little bit longer. And when you're sleeping, you don't really need to feel it kick in. So in my office, that's what you'll see me do a lot. Now, because of that fact, they came up with Ritari and Crexont. So because of the fact that the IR version works the best and kicks in, and because of the fact that it doesn't last as long as the CR, some smart person somewhere, and I don't know who it was, said, well, what if we put those two things together? And they did that. And they put it into a capsule and they called it Rotari. And in some patients, it does indeed do that. I would say some patients who take it feel it kick in, but also feel like it lasts longer than regular Cinemet, which was the goal, which is why it was invented. And then fast forward, the same company, probably the same person, said, well, what if we make it even a little bit better? And that's what Crexont is. So Rotari and Crexont are both immediate release and controlled release carbidopa levodopa in one capsule, with the idea that it might kick in as well as the immediate release, but last as long as a controlled release. And I do use Rotari and Crexont during the day as well as at night. My experience, and this is my opinion, has really been kind of 50-50. I would say maybe 50% of people, when I switch them from either regular Cinemet to Rotari or regular Cinemet to Crexont, think it really does work. It works better, it lasts longer, they feel it work, they like it. And the other 50% say, it's not much different, or it's no better, or it's a little bit worse, and they switch right back. And I have not been able to really pinpoint or figure out who's going to do well with it and who hasn't. It's a lot of trial and error. But that's why you usually will not see me use the Cinemet CR during the day, whereas I will use it at night or I'll use these other versions. But that's the very long answer to that relatively simple question. I'll extrapolate this to everybody else, but at the end of the day, yes. So this is a patient who woke up early, middle of the night, probably without thinking, because I do strange things when I wake up in the middle of the night. Took her pill. Oh, I don't usually take my pills until 6:30 in the morning. Here I am at 3 o'clock in the morning taking my pills. What do I do? Realistically, if, and I'm not suggesting you call the on-call doctor, but if you wanted to ask me, I would have said just take your pills at 6:30 and just take it like you took an extra dose. Mainly because I don't think it's not gonna disrupt your daytime symptoms very well. If anything, it might help a little bit, but I don't think there's a large risk to taking a pill that close together and even taking an extra pill. So if your normal schedule was at morning, afternoon, and evening, I probably would have just said chalk that up to taking an extra pill by accident. Get back on your regular schedule the next day. Um, some people would say, well, maybe I shouldn't take that first day. Maybe I should shift all of my pills, but I don't think that's all that necessary. Regular carbidopa levodopa really is not that long lasting of a drug. Maybe initially people will get 5 or 6 hours out of it, but I would suggest that as time progresses, you usually get closer to 3 to 4. And again, it would have been worn off by your morning anyway. I don't know that it would have made a difference. Again, might it have given you a little bit of an extra boost, or might it have amplified side effects if you do have side effects like hallucinations or dyskinesias? I don't know. I doubt it would have been that dramatic, but I would have, if you had have called me at that time, I'd have said, just take your pills normally starting the next day. Don't worry about it. Go from there. There is some, and I get that question actually a lot. Hey, if I'm a little bit late taking my dose, can I take it and then take my next pills at the same time? Again, you can. I don't know that I would try to put them that close together, especially if you are prone to dyskinesias or hallucinations. Taking them that close together could amplify those things. But realistically, there is a lot of flexibility or leeway in terms of taking your medicines. It's all a matter of kind of symptoms and side effects that you can put up with. Does Parkinson's disease get you overheated during the day or at night? Does it make you get very sleepy during the day? What should I expect from taking carbidopa levodopa? All great questions. Parkinson's disease, not usually initially, but can affect the autonomic system. And your autonomic system is what is the system that not only controls heart rate, blood pressure, things like that, but a little bit of temperature as well. I do get patients who say they get hot flashes or they get overly cold. Now, is that related to the disease or the medications? I'm not sure. I can't think that anybody has ever come before I put them on medicine and said, hey, I'm having these symptoms. If you have strong autonomic features, then that might lend itself to a different type of Parkinsonism, but I'm not sure. And so the easy answer is to say yes, Parkinson's disease can affect just about everything and everybody. But I think that would be a little bit unusual, especially early in the course and before you start taking any medicines. All of my patients are sleepy during the day. Fatigue and tiredness is the number one complaint that I get coming into the office. My opinion, and I don't know that I've ever seen this backed up in literature, but I learned this from my mentor, is that kind of early afternoon or late afternoon, early evening is just a natural decrease and decline in dopamine levels across the board in everybody. And so if you're already dopamine deficient, you're going to feel it the most. And so it tends to be that 2, 3, 4 o'clock time when a lot of my patients take a nap and they feel very down and withdrawn at that time. Again, I do think the disease is tiring, partly because your systems have to work in overdrive, but partly because you have to think about every little detail and every little thing you want to do. And that's very mentally fatiguing and tiring. And so, again, the number one complaint that I get walking in the door after we get past frustration, which is probably the number one word that comes into my office, is fatigue and tiredness. And so, yes, most of my patients are tired and sleepy. And again, I do think that's a side effect of the medicines, but I also think it's an underlying part of the disease. And the expectation for taking carbidopa levodopa is questionable. I mean, if you do indeed have true Parkinson's disease, then I would expect you to have some noticeable benefit to carbidopa levodopa. If truly the problem is lack of dopamine or dopamine deficiency, levodopa is as close as we can get to replacing dopamine in your brain. And so, again, you can imagine if you have a dopamine deficiency and I replace some dopamine, you should have a noticeable difference. And so, if you do indeed have true Parkinson's disease, I would expect carbidopa levodopa to help some. Do I expect it to be a miracle pill? No. Does it sometimes? Yes. But does it oftentimes? No. Would I expect it to take away your symptoms? Probably not. But would I expect you to have a noticeable benefit to the medicine? Yes. I would expect you to come back to my office and say, I'm not perfect, but I was a little bit less shaky. I was a little bit less slow. My walking was a little bit better. It was a little bit easier for me to get up out of a chair, roll over in bed. Those are the things I would be expecting and looking for, and those would be the things I would build on and base my next decisions on whether or not you get more medicine. I layer in something else to see if we can maximize the benefits and get you doing better. Would taking a dose of Cinemet at bedtime help with sleep pattern? Maybe. And here's why I say that. And everybody's individualized. It's a little bit different. But a lot of my patients wake up in the middle of the night, and they wake up in the middle of the night either to go to the bathroom, which I feel like everybody does, but they tend to wake up in the middle of the night at a specific time. And a lot of times, not always, but a lot of times in my patients, it just also seems to happen to fit the same interval time that they take their pills during the day. So if you take pills every 4 hours during the day or every 3 hours during the day, and then you find you wake up 4 hours after your last dose of medicine, those kind of things always make me wonder, is it because your pills are wearing off? Is that what's waking you up? Or if it's not what's waking you up, is it at least what's making you stiff or shaky and slow and have a harder time going back to bed? Because I hear about that a lot too. And so if that's the case, if the wearing off of your pills is indeed kind of either the culprit for what's waking you up or the culprit from what's preventing you from going back to sleep, then yeah, adding a dose of Cinemet around bedtime or something longer lasting or something during the night might be a good way to work on that. If it doesn't seem related, or if you're sleeping okay and it's not really, and you're feeling okay when you wake up in the morning, then maybe it makes sense to cover your awake time hours with the medicine as opposed to taking it at night. But that's a very subjective thing. I have plenty of patients that take medicines at bedtime and it seems to help. I have plenty of patients that don't take any medicine at bedtime and they do okay. Excuse me. So everybody's regimen is a little bit individualized, but those are the things, those are the things I'm looking for. If somebody comes to me and says, "Hey, you know what? 2 o'clock every morning, I'm up and I can't get back to sleep. Oh, by the way, I take my pills every 4 hours and my last dose is at 10 p.m." I say, "Really? No kidding. Let's work on that and see if we can do better." Sometimes it works, sometimes it doesn't, but paying attention to those kind of patterns is important to help us decide what to do. Um, so the question is, how about Mirapex? But I'm not exactly sure what you would like to know about Mirapex. Um, are you talking about again with sleep patterns, or are you talking about Mirapex in general? Um, at the end of the day, Mirapex is probably the second most potent drug that I have. So after the different versions of carbidopa, levodopa, pramipexole is probably the next most potent drug that I have. And so if I have somebody who needs another fairly potent medicine, this is where I'll add in Mirapex. Um, the caveat to that is, again, Mirapex is a dopamine agonist, so it tends to come with a different or more side effect issue, particularly impulse control problems. So Mirapex is almost across the board the drug you'll hear about: gambling problems, sex problems, eating problems, shopping problem. I was like, there's another one, but I can't remember it. It can happen with Requip or Nupro or even Cinemet or any of the other medicines, but the one that tends to be the biggest culprit is Mirapex. And that's because it directly activates dopamine receptors, and it does so not just in the movement pathway, but also in the limbic pathway. Um, the downside is a really good medicine. Again, it's probably the second most potent drug that I have. It just has to be used cautiously, and we have to pay attention to those things. Again, I would argue the same thing if the question is in regard to the sleep patterns. I mean, again, if Mirapex is usually a 3 times a day drug, if you can find a pattern for how long your intervals are during the day and see that that also extrapolates to bedtime and nighttime, then it probably makes sense that it's the medicine. Interestingly enough, Mirapex also comes in an extended release version that's just one a day. And so coming back to something we talked about before, which was that dopamine dysregulation syndrome, or that addiction property to the dopamine medicines, usually one way we try to work on that is by switching to the longer lasting or longer or extended release version of medicines. So Mirapex comes in an extended release, Requip comes in an extended release, Nupro comes in a patch. These would be the versions you would try to get to if somebody is really having a lot of those problems. Again, same thing is true for carbidopa, levodopa. The longer lasting ones or the extended release ones might be better for stuff like that. But at the end of the day, again, I'm not sure what you were asking specifically about Mirapex, but I could talk about any of these things for as long as you want, but I feel like you guys would get bored if I start getting into things like that. And if I'm not mistaken, Casey, that really is the bottom of the question marks here. So this may be the
Wow.
first time we actually end relatively early.
Right. We'll give it like another minute if anyone has any
Sure.
additional questions or two.
What's going on in the foundation? Anything going on, Casey?
Well, we're getting ready for, let's see, we're having a music therapy program. That's going to be in person at the JCC in Squirrel Hill, and that's starting in February. We're gonna have another word wellness workshop for expressing through written word. That will be virtual in March. We have the PD parlor this month on the third Thursday at 1 o'clock. It will be on cognition again, and it will be recorded. Oh, it looks like Vicky and Donna have raised their hands.
Go for it.
Hi, I just had a question on DBS. If if you get programmed and it happens to have be and you left the office and it's kind of a bad program in that it's causing some bad side effects. If you're left on that program for say 3 months, is it still reversible, the side effects, if they change the program?
Great question. And I don't know the answer to that question, but great question. My first inclination, and I don't know that this has ever been looked at, because generally I would hope we wouldn't leave people on a bad program for that long. But it does beg the question, what are the long-term effects and how permanent are the effects of stimulating the brain, right? So for those of you who don't know, just a quick update. So deep brain stimulator surgery is a surgery we'll do for Parkinson's disease, where we'll implant wires and electrodes deep into the brain, and then we'll stimulate the deeper structures to disrupt those abnormal firing patterns that we know happen in the brain that lead to a lot of the symptoms. I don't know that that's ever, I'd have to look. I don't know that that's ever been reported in Parkinson's disease, but let's say you use a different electrical problem or electricity stimulating condition, i.e., seizures. So seizures are really just abnormal firings that group together that lead to an overall seizure. We know that if seizure focus is left untreated, it can not only become permanent, it can also spread and cause another location to also misfire. And so if you do have uncontrolled electricity in the brain, it can do permanent damage. At least that's what we've seen in epilepsy. Again, can that also happen through deep brain stimulator type of electrical stimulation? I'm not sure. I don't know that it's ever been reported or looked at. I feel like that would be a really hard thing to study or be sure about. But logic would tell me that yes, if you did cause an abnormal firing or circuitry pattern for long enough, it could become either more ingrained or permanent or more difficult to get out of. And if that firing pattern did cause side effects, then I think those side effects would be tough to get rid of. Again, I'd have to look and see if anybody's actually documented that or written about that. That's just my guess and my understanding for kind of how stimulation works in the brain. I think the key would be again trying not to do that. Obviously, if you do a DBS adjustment and it doesn't work well, then we certainly have to either try to switch again or do something a little bit different if that's possible, or if nothing else, revert you back to where you were before we changed it. Um, but I'm not sure I know the answer for sure. I don't know that that's ever been looked at scientifically.
Okay.
Treatment of dopamine dysregulation.
What was it?
My sister's asking about dopamine dysregulation, Vic.
Treatment of it.
Treatment of dopamine dysregulation. Is there
Sure.
treatment?
Yeah, so what we try to do is we try to slowly decrease the medicines. And in particular, what we'll do is switch from immediate release to extended release versions. Sometimes things like naltrexone are used. Um, this is an opioid agonist antagonist. It's used in a variety of other things, but sometimes it might help with that dopamine dysregulation or that agitation or that withdrawal syndrome. But at the end of the day, what you're going to want to do, or what we're going to try to do, which is extremely difficult, by the way, I say this like it's very easy, but it is actually extremely difficult, is to not only switch to a longer lasting version of the medicine, but then to slowly systematically titrate down. It's not easy and it's not always successful, but that's what we would try to do.
And when you're getting DBS, I've heard from many neurologists, they really don't know how DBS works, but they just know it has good effects. So it got
Correct.
so then they really don't know if it does permanent damage either, but it's been approved by the FDA if you go set it on a bad program. So I just don't
Correct.
understand how we can continue like that. And if it takes so long to program people, yet your programming sessions at most lasts an hour to 45 minutes because there's so lack of programmers, and get off a bad program is really difficult. So how do we go forward with DBS?
Well, kind of the same way we've been doing it, just with better communication is really what it is. And they do keep coming up with newer things. Ultimately, the goal of DBS is to have a self-learning, self-programming deep brain stimulator system. We're not there yet, but that's the idea behind Precept in terms of recording and measuring to eventually be able to adapt. So we do have other stimulators in other conditions, mainly epilepsy, that are self-learning and self-programming, and that's eventually what we're hoping to get to in Parkinson's disease. But the communication is key. I mean, because you're right, a lot of times we'll adjust somebody and they'll do great in the office. They'll look great, and then they'll go home, and the next day or the day after, they're like, "Oh, I fell apart. I'm terrible." And that's where, again, we got to bring you back in, or we at least have to give you some leeway and some power to change things. One of the DBSs, and again, I am not an adjuster. I'm terrible at it. I learned how to do it a while ago, but I just don't do it enough to be good at it. One of them you can adjust remotely, and so I think that also will be the wave of the future. With future iterations of deep brain stimulators. And again, the key to think about DBS is it is not a fix. DBS is not a fix. DBS is not a cure. DBS is another tool that I have to try to help people do better. It's not for everybody. It's not for every symptom that we have. We try to select people as best we can, but we get it wrong sometimes. There's no doubt about it. But the idea is not to fix people or cure people or take you off your medicines. The idea is to help you function better. And in the right person, in the right circumstances, we can do that, but it's not always as good as we'd hope.
You said that they do have a self-adjusting system for seizures.
So there is something in epilepsy where they implant it completely into the skull itself. So it's all intra skull. And not only does it record, but it also reacts to try to stop seizures. Now, again, seizures are a little bit easier to pick up, record, detect, and prevent than, say, the beta bands in Parkinson's disease. And so this is why I don't think we've quite got there yet from a DBS standpoint. But again, every time I talk to the DBS companies, I ask them for the same thing, which is a self-programming, self-adjusting, all intracranial device. And they say, we're working on it. That's the wave of the future.
And I read about a study that was about a guy that it was up in Canada, and they adjusted his DBS by he was wearing a helmet, and they were
Mhm.
looking exactly at the signals in real time
Mhm.
instead of relying on the DBS to do signals to measure things. They were measuring it on his head, and they adjusted they had made adjustments, and he got a much better outcome than through traditional programming. Have you
Sure.
heard of that?
I did see something about that, but it was a very it might have only been one person or a very small group of people, so I think it's something that still has to be looked at a little bit further. But again, they're always looking at stuff like this and they're always trying to figure out better ways to do it.
Okay. Thanks.
Well,
Sure.
that sounds hopeful. We'll end on a hopeful note.
And I just want to put a shout out to everybody. On Thursdays, the Parkinson's Society runs yoga with Jen Straukas, and it's excellent to control breathing, to control some of your symptoms. So let's do some natural stuff. And I recommend anybody that has internet access to take the yoga. It really helps. I'll just do a
Thank
shout
you.
out for that class.
Thank you for that shout out. And yes, we have many virtual exercise classes. And that reminds me that we will have a Saturday class now. It's a moderate cardio class virtually at 11 a.m. and a Tuesday evening class with the Saturdays with Chris Steinmetz, and the Tuesday evening class at 6:30 is with Janine Hartman. So stay tuned. The newsletter will have all of that information in it, which I think will be coming out tomorrow.
Great. Thanks, Casey.
Okay.
Happy New Year, everybody.
Happy New Year. Bye, everybody.